Now, how can one miss an elephant in the room? And this is something to think about. We can suffer from a cognitive bias as an unintentional blindness or perpetual blindness where we can't see the problem. It could be a visual field effect. In the case of TB, I think there is a tunnel vision. I do not, the germ theory has given us many useful things in TB, in terms of diagnostics and therapeutics, but it has also constricted our vision, and we sometimes don't see the larger picture. And finally, Douglas Adams, in one of the novels, wrote about the ACP field or somebody else's problem. And this is something that we can't see or don't see, our brain doesn't let us see because we think it's somebody else's problem. And that partly is, sometimes the, view on undernutrition and poverty in terms of TB. There have been some fragmented views on the whole problem of undernutrition. Some people, from their own perspectives, emphasize the increasing prevalence of obesity rather than the persistence of undernutrition in the world. Some people limit their discussion on, maternal and child nutrition and pay little attention to adult nutrition. Micronutrient versus macronutrient is another dichotomy which is artificial, and other things. So, but in the case of TB, I think it's important to know that it's important across age groups. Undernutrition here, both macro and micro are important, and TB is both a cause as well as a consequence of undernutrition. Undernutrition can result from active TB because of disease-related malnutrition because of inflammation. But the kind of nutrition status we see in countries like India is not just because of the disease, but it's a combination of hunger-related malnutrition and disease-related malnutrition. And that is the reason why we see such low levels of nutrition in patients with TB in India. Just highlight some the evolution of TB strategies to lay the context. So the DOTS plus strategy, which was operative between these years, basically concentrated on case detection and standardized short course chemotherapy and direct observation. The Stop TB strategy took this a little ahead by incorporating treatment of TB HIV and multi-drug resistant TB and talking of health systems and engaging all care providers. But it was basically still TB treatment plus some comorbid conditions and MDR-TB. Now the gap here is in these treatment-based strategies, which can explain why they have not been successful in decreasing TB burden is the cases of TB are arising of this huge pool of patients with people with latent TB infection, an estimated 1.7 billion globally, out of which only a certain proportion are developing active TB. The TB treatment strategy really just interrupts transmission to other people and shortens the duration of transmission really. But there is no currently widely applied strategy for preventing progression from latent TB to active TB. So the LTBI treatment poses a lot of operational issues because of the large numbers. We don't have an effective vaccine which can prevent adult TB. So the thing is that we should still, like in the case of non-communicable disease, address the risk factors, of which undernutrition is a major one. So thankfully, the current NTB strategy is a more comprehensive kind of strategy which addresses these other issues. And for the first time in the TB strategy lexicon, there are words which have to be converted into actions if they have to mean anything. So the underlying thing is, principle is supposed to be the protection of ethics, human rights, and equity. In the case of TB care, the strategy talks of patient-centered care, patient support, and addressing comorbidities. And in the case of TB prevention, it talks of social protection, poverty alleviation, and other social determinants. And if we reflect on the problem of undernutrition, actually it fits neatly into all these, new emerging themes. So we know that M tuberculosis is a necessary but not a sufficient cause of tuberculosis because immunity plays a critical role and undernutrition impairs immunity. So undernutrition is a risk factor which needs to be addressed. in high TB burden countries, which have a significant undernutrition problem. People do not die of TB, but they die of severe TB or severe comorbidity or both. So factors which will increase the extent of severity of TB, which includes HIV and also includes undernutrition, are important to address if we have to prevent TB deaths. And finally, a TB program is necessary but not sufficient to prevent TB poor outcomes in patients, because this is linked to social determinants. And work has shown that if you talk of poverty and the relationship of poverty and TB, a major part of it is mediated also through the pathway of undernutrition, which is closely linked to poverty. Nutritional wasting has always been associated with tuberculosis. So it was surprising to us to find in our work in rural India that there was not much data on what were the nutritional status of patients at diagnosis and after treatment, and what was its impact with TB mortality. So this was a paper of nearly 1,700 patients of about 5 years data, and conducted in rural India. This is probably again some of the lowest weights recorded anywhere in the world at that time, and it indicated high prevalence of severe undernutrition with BMIs going down to 10, median weights in adults being 42 and 34 in men and women. Again, 50% were below this, and these were thought to be extreme kind of weights, but later the national program figures were not very far off from these figures as well. And these levels of undernutrition were potentially lethal, increasing the risk of mortality by 2 to 4-fold. Now, people often talk of a bidirectional relationship between TB and undernutrition, but actually it is a vicious cycle, where undernutrition, by impairing immunity, leads to tuberculosis, which in turn worsens the undernutrition because of its effect on appetite and the cytokines. And this in turn makes the TB more extensive. And this worsening cycle of undernutrition and more extensive TB culminates in death. And undernutrition has been found to be a predictor of early mortality in TB. We also found in this cohort in rural India that weight gains were very suboptimal in the absence of nutritional support. So patients from very severe undernutrition became moderately severe by the end of therapy, a median of 3 kg weight gain only, and most remained undernourished even at the end of treatment, which has its own implications for long-term outcomes in these patients. Now, this is a photograph actually in a letter in 2014 submitted to a journal from our group in Janswa Sayo. And it was disturbing to see that the same low weights persisted. Now, it might seem that, the attention to these low weights really happened only because of our last study, but actually, even in the case of the Madras trial, the famous trial of home versus sanatorium treatment, when we look at the data, actually the weights were very, very low. And the weight gains were actually much higher in those who were provided sanatorium treatment with a better diet. So I do not dispute the fact that it was a landmark study, but somehow the message that diet will not play any important role was probably the wrong one. And patients who are severely underweight were deprived of the benefit of a better diet for years. Not only was diet, not available to patients, but drug doses in Indian patients was, in terms of weights, was ignored for many years. And this was pointed out again by a study from what was at that time called Tuberculosis Research Center, Chennai. Now it is NIRT, which pointed out that actually Indian patients were receiving much higher doses, which had been established for Western patients without adjustment. And in this national program document in the 1997, of course, there have been corrections later, but initially patients were given drugs, all adults were given the same, dose irrespective of body weight. And we realized the horror of this in our rural program, where a 28 kg patient was given the dose which would have been given to a 45 kilo person. She developed seizures, fell into the fire, and sustained serious burn injuries. Undernutrition contributes to morbidity, mortality, response to treatment, and long-term outcomes. So it's important both to address during treatment, and it has its effect even post-treatment. So undernutrition has been known to increase the extent of disease, pose a higher risk of death, which is about threefold higher risk of death, almost 5 times higher risk of drug toxicity with a BMI less than 17. And notably, absorption of key drugs like rifampicin has been noted to be impaired in some studies in undernourished patients. Low BMI and low weight gain have been associated with delayed sputum conversion. Anybody interested, I can just direct them to the evidence. I'm just summarizing it here for the purpose of saving time. If a patient gains weight poorly, he is less likely to return to his livelihood, which is often manual labor. And even fourfold higher risk of relapse has been seen in undernourished patients post-treatment. There is one other thing of utility when you assess the nutritional status. It's a very can serve as a good proxy for severe TB, because nutritional status and ultimate tuberculosis is closely related to severity, and which can predict mortality. So in the guidance document for nutritional care and support in India, we have recommended these indications for referral and possible inpatient care for patients with tuberculosis. Often the issue of nutrition support in TB patients, the discussion veers around to the Cochrane systematic reviews on nutrition supplements for patients with active TB. And usually the comment is that there is no evidence that nutritional interventions have any benefit. But actually the fine print is that the Cochrane review said that there has been insufficient research in this area to decide really whether they have any beneficial effects on outcomes. So the first Cochrane review in 2008 did not report any trial, the impact on death. There was only one trial which reported weight gain. In the second Cochrane review version, there were 202 patients in 2 trials which were given macronutrient supplementation. There were other trials with micronutrients. And in 2016, there were a total of 567 patients in 5 trials enrolled so far, where the effect of food, supplementation or high energy supplements had been observed. All these were small studies, underpowered, but there was a potential, reduction of TB mortality seen in this, which was not statistically significant. So the number of patients dying with TB in India every day is about 1,200, and we have only half that figure in RCTs enrolled till now. So this has been a neglected area, but I wonder now whether it is at all ethical to randomize severely underweight patients to control arm. So I don't think you can ethically do a trial on this anymore. Also, the fact is that in all this evidence, we have never really elicited what patients feel and what are their values and expectations. And if you take that into account, the jury would be saying something different. Fortunately, the WHO took the Cochrane evidence into account, but made a pragmatic guideline which suggested the recommendation was that nutrition assessment, counseling, and support are an integral part of TB care. However, the uptake of this globally has not been very good, but India is one of the countries where we adapted this guideline and recommended food support to all TB patients. And these are some of the initiatives in India. The guidance document on nutritional care and support, which suggested food support in kind. And I was associated with this formulation of this document. An app was developed to facilitate nutritional assessment and counseling, which was actually developed with support from the McGill TB Center. But in 2018, because of the operational difficulties, the government decided to give a direct benefit transfer of 500 rupees a month to enable poor patients with TB to get a better diet. And there has not been an impact evaluation of what has been the impact in nutrition and clinical outcomes of this. But this whole strategy is currently probably being revised. The second thing was recognizing the proportion of TB incidents in India attributed to undernutrition. I'll just quickly go through this. everybody is familiar with the simple formula for estimating the population attributable fraction, which is the fraction of the burden of disease which could potentially be eliminated if a particular risk factor were to be eliminated. So here we took the prevalence of undernutrition from the prevalence of low BMI in a national representative sample, the NFHS3, and a risk ratio from a study by Sejelski published in 2012. Because this was one of the few studies where the cohort was from a national representative sample, and they had particularly seen TB incidence below 18.5 BMI. So, as I've already pointed out, prevalence of undernutrition in adults was high in India, and this was especially higher in rural areas and in some of the population groups like the scheduled tribes, and of course amongst the poorest. And if you plugged in the prevalence and the risk ratios here, we estimated almost half of TB in India could be attributable to the effect of low BMI. And this was again higher in the poorer groups and the marginalized communities. Now that TB nutrition could have an impact on TB incidence, was there any evidence from the literature on whether adequate nutrition could reduce TB incidence? So there were no trials, but one of the hypotheses raised was by McGill, who looked at the TB mortality data in UK from 1850 to 1950 and saw that the decline in mortality antedated the discovery of BCG vaccine or chemotherapy, so it was already declining, and he attributed this to improving living conditions of living, of which he considered adequate nutrition, improving nutrition as the most important. But there's been a lot of controversy around this. But what we saw when we revisited the experience of the Papworth settlement provides one proof of this McGill hypothesis. So this was a village settlement for TB patients and their families set up by social pioneer Dr. Pendrell Warrior-Jones, and it provided better housing to these families. They had stable employment, which was in modified conditions. They were doing labor which was not heavy, and there was an emphasis on adequate nutrition. And they followed up all the families who were admitted to the settlement, including particularly their household contacts, for development of TB disease. So the key findings there were that although there was better housing, this did not prevent infection, and infection was universal by age 5 in the two cohorts of those who were admitted into Papworth and the children who were born in it. There was zero incidence of TB in children less than 5 years of age who were born in the settlement, although they had been exposed to disease and were infected. And overall, there was quite a dramatic reduction of TB incidence when in the contacts when they came to stay in Papworth. And again, because they were already infected, this decline was because of decreased progression to active TB from infection. So this is actually fairly robust evidence from an observational kind of study on the effect of social interventions on TB incidence. And Warrior-Jones, said about food in TB versus fresh air, that actually fresh air is the second most important thing because for protection against disease, nutrition is vital. Again, in the pre-chemotherapy era, there was one natural experiment often quoted where British soldiers who had a Red Cross food ration, providing them extra calories and proteins, had a very, very dramatic 90% reduction, lower incidence of TB compared to Russian soldiers who were living in the same conditions but were having access to a present diet. So taking these things forward, this is a slide I've used earlier, but food rations in undernourished populations can act as a vaccine for TB, and which has all these useful things which you would look for in a vaccine. Oral polyvalent vaccine without IPR issues and safe in women and children, and with guaranteed compliance. So finally, I would discuss the ration study, which is currently testing this hypothesis, whether addressing undernutrition in communities with a high prevalence of undernutrition can reduce TB incidence. So this is going on in the state of Jharkhand in eastern India since 2019 August, and it's our collaborators are colleagues from the National Institute of Research in TB, and this is funded by the ICMR. So this ongoing study is in 4 districts of Jharkhand and over a very large area in 24 treatment units. So it's a cluster randomized trial where in one arm we are providing the patients with nutrition support but not the family members, and in the intervention arm both the patient and the family members are given food rations. The primary objective, as I said, was to see the effect of this nutrition supplementation on TB incidence amongst household contacts over a period of 2 years after diagnosis of the index case. And we are looking at a number of secondary objectives. Is the effect on weights in patients and contacts. In patients, we are looking at whether this affects adherence, mortality, frequency of major side effects, performance status, and eventually recurrence of TB within 2 years also. And among contacts, we are also looking at what this intervention might have an impact on non-TB infections. We have a number of sub-studies here on smaller samples of patients and contacts, evaluating their baseline intake of calories and proteins and then after intervention, estimating micronutrient status, evaluating body composition and changes with the intervention, and also looking at lymphocyte subsets in both patients and contacts at baseline and following therapy. These are some glimpses from this wonderful state, from the field, and some of the most beautiful, villages and rural houses I have seen only in Jharkhand. This is a typical Santhali house. You can see the problem of public transport. Jharkhand has a very high forest cover, which poses a lot of challenges operationally. So the patients in our trial, in the both arms, are getting a 10 kg food basket consisting of rice, roasted Bengal gram flour, milk powder, and oil, along with multivitamins. And the family members in the intervention arm are getting per head 5 kg rice and 1.5 kg pulses per month, along with multivitamins. And the cost of this intervention is actually very modest if you see it in dollar terms per day. So we have the procurement of these food rations is central, and then it goes to sub-depots. And from those depots, it is taken by the field staff to the household of the patient. Some patients also pick up the rations from the depot if it is more convenient for them. And because of the amount of food rations, we have transported more than 1,100 tons over this period, which has included the COVID pandemic period. So it has been a huge challenge, and full marks to the team there who has kept this going. So the terrain is very challenging. There are often no roads, and sometimes they have to even cross these streams while balancing the food rations and their equipment. But the experience with the patients has actually made it all worthwhile. So the field staff does a comprehensive home-based assessment, and I think this should be available to all patients in the future. TB is one disease where we do not have any risk stratification at diagnosis. There is no, clear, mention in the guidelines of clinical assessment. So these patients are getting assessment of vital signs, the weight, heights, and the BMIs. We are measuring their performance status with a simple modified ECOG scale, which actually in 4, the scale of 4 means that the patient is bedridden, and 0 means he's completely ambulatory. We are also assessing hemoglobin, and based on these above, assessments, the field staff makes an assessment whether the patient requires further referral for inpatient care. Often this referral doesn't work because of the family's reluctance, the issue of transport, etc. Of course, they're all following up patients' contacts for symptoms and then doing the evaluation on them. So they carry portable stadiometers and machines, and some of the children are very enthusiastic about repeated measurements, as seen with this child. This is hemoglobin estimation in the field, and for the first time, probably we were doing body composition assessment in the field with a multi-frequency bioelectrical impedance analyzer. And of course, you can see the state of wasting in this patient. I'm happy to share this slide where the field staff has made this assessment. In a 52-year-old, the weight is only 31 kgs, the BMI is 13, the patient has hypotension, has severe anemia, and this patient was again referred. Everything is there. And if you look at the baseline characteristics, we have relatively young population in our trial, with again a preponderance of males. The striking thing is the high proportion of patients who are indigenous, from the indigenous population of scheduled tribes. They are more than 2/3. High percentage are illiterate. Family history of TB and TB deaths is also not uncommon, and tobacco use and alcohol use is also common. Again, what we were disturbed to find is, again, the weights were virtually identical to what we documented in another state like Chhattisgarh more than a decade ago. And again, they are in the same range of 41, 42, and 35 kgs in women median. And again, BMI is median around 16. Our lowest BMI in a patient has been 8.2. So, again, some more facts about their nutrition status. A very high percentage are underweight. Nearly half are severely underweight. We have another cutoff of BMI less than 14, and even there 1 in 6 patients has a BMI less than 14. And anemia is very common, and all the other comorbidities that we talk about, diabetes and HIV, are less frequent. MDR TB also in our cohort was not significant in numbers. Again, this slide shows the nutrition status of contacts. The BMI, again, we're talking of a national average of 18 in women and 16 in men. This is almost double of that in this impoverished community. Again, significant underweight in children. Other interesting findings in the baseline were that actually we found lower levels of micronutrient deficiencies, and this refers only to vitamin A and D. Vitamin A levels can be lower in TB, active TB, and they can return to normal. They had very low rates of levels of baseline energy and protein intakes, and CD4 lymphopenia was seen in the majority of these patients who are actually HIV negative. So this is a journey of a patient, initially bedbound, 18 years old with a weight of 26 kgs, a BMI of 10.7, starting to walk with a stick at this age of 18 after a few weeks, but now fully functional, but still has not crossed the threshold of 18.5 despite a weight gain of 16 kgs. Another patient, again, showing recovery within a few months to work, and he was actually wanting to show our field staff that he can now do manual work again. So in the context of patient-centered care, in the context of the NTB strategy, I think along with effective anti-TB treatment, food support in us and financial support in a country like India, along with supervision, should define this concept of patient-centered care. And nutritional care should incorporate nutritional assessment, education on diet, and nutritional support, which can be community-based in most. Often, food support is seen as an incentive and enabler, and I think that is a wrong thing to frame it as. Patients who have moderate and severe undernutrition require nutrition support as therapy. A lot of patients who are maybe mildly underweight are also experiencing food insecurity, so nutrition support is a form of social protection for them. And of course, for everybody, it can act as an incentive enabler. One other thing which is coming out from this trial is that food support may be graded, because some patients will require more of the quantity for a longer duration of time. and it cannot be a uniform package for everybody. This is for each program to assess, depending on how severe the undernutrition there is in the program. Because the whole cohort has finished 6 months of TB treatment, we are in a position to comment on the secondary outcome of deaths here. So, in a recent cohort whose study, results of published in 2018, the mortality was 6%, and this represented, patients from 6 states in India. We do not have a control arm here in terms of the patients, so we can only compare it with other cohorts. And reported mortality in those below 35 kgs was, even lower in our group. So overall, actually, mortality has been significantly reduced by this package of interventions in the cohort here. If you translate these absolute reductions into number needed to treat, it gives actually very promising values, which are comparable to, for example, use of dexamethasone in patients with COVID infection, hospitalized patients. The other outcomes that we found was definitely lower rates of default. We have been detecting, keeping a close eye on relapse, and till now there has been a relapse rate of 3.4%. The national figures are around 10% within 2 years, but we are still, not completed follow-up in all. And we have detected more than 150 cases of active TB in the household contacts. So I will end this presentation by saying, what then should we do? I think overall the one message is give undernutrition the same attention that is given to HIV infection, TB care and prevention. So when we talk of patients, everybody is tested for HIV co-infection. Everybody should have undergo a nutritional assessment as well. And like for ART, there should be a provision of nutrition support. And at the population level, unless we reduce the numbers of people with HIV infection, TB will not be controlled in sub-Saharan Africa. The same goes for TB and undernutrition in South Asia. I think the first message is to address undernutrition in patients with nutrition support. This is something that it is something in our hands to advocate for and demand. And I think delaying or denying nutrition support to severely underweight patients is both scientifically untenable and morally inexcusable. I think a lot of people are dying due to a cause which is completely, preventable. We should assess undernutrition in the population and advocate. We cannot address it, but we can advocate for addressing undernutrition in the poor as part of the social protection and as part of achieving SDG goals. And there's a huge scope for conducting research in TB undernutrition interactions, which can be basic science, clinical, epidemiological, and implementation research. So these are some of the research priorities related to this theme, which have been highlighted in an article by Pranay and team. I've also contributed to this, and the paper has been published last year in Lancet ID. And I'd just like to say that there have been some recent positive developments in this neglected area. The Report India Consortium is doing a TB line study, learning the impact of nutrition on immune response. So there have been articles not only by academics like Pranay, but also by, for example, the Southeast Asia Regional Office of the WHO has recently published this in the January issue of the International Journal of TB and Lung Disease. So this is the picture of our field team taken in August 2019. I owe it to them for keeping the trial going and achieving what we have done so far. And my grateful acknowledgements to the field team led by project consultants Ajay Mehar, who's on this call, Vivek, Dr. Dhananjay, our other team members, including the 56 field investigators, my colleagues, Dr. Madhvi and Dr. Banu Rekha at NIIT, and our colleagues at the State TB Cell, Departments of Medicine at Yenagoya, and of course, to the people who have supported us, the India TB Research Consortium, DIC, Central Coalfields, and others, and Let's Dream Foundation. So I'll end here, and I'm open to any questions or comments.
Great. Thank you, Madam. Madam. Thank you, Anurag. Sorry I missed at the beginning. I'm here on the ward. I wonder if people have questions or comments. It's, as Madhu wrote, fantastic work, very impressive, particularly in the face of COVID. So usually we allow this. Yes, Edgar has. So we start with the students. We have the toughest questions, of course, and then move on. So Edgar, you had your hand up there for a minute?
Yes. Thank you. Good morning, good afternoon. Thank you very much for the talk. It was very inspiring, very interesting topic. I have two questions. The first one is if you have had any problems with refeeding syndrome with these patients. So it seems like it's very important, like the nutrition in the patients. So I was wondering if when patients receive the food, if they have had some problems with refeeding or so, because in Mexico, these kind of patients, when we have these levels of undernutrition, we usually treat them in the hospital, but I know this is a different context, so that is my question. I think you're
muted.
Mm-hmm. Yeah. Thank you for your question, Edgar. And I recognize that refeeding syndrome is a potential complication of feeding in patients who are severely underweight and may also have electrolyte disturbances at baseline. So your point is well taken. So we, as you saw in the slides, we are trying to recommend all severely underweight patients to to the public health system so that the feeding can be initiated in patient, but that doesn't often happen. We have not seen any. We have trained our field staff to recognize some of these manifestations of refeeding syndrome. But there was one study done at Janstrauss Sayog in Chhattisgarh on the frequency of refeeding syndrome in similar patients. So although they found that there was some decrease in the levels of phosphates, but really clinically these patients did not really develop any refeeding. So probably I think TB is a unique situation where they have poor appetite at the, they're not like a person in a famine situation where they will start eating very well. So the appetite is also low. So actually, inevitably, there is the process is gradual rather than suddenly somebody will start eating a lot. But yeah, that is a concern that has been expressed, and we have not had any death so far or any other complications which would suggest a refeeding syndrome.
Thank you very much.
Any other students for the question? I know there's a few, Marcel and Maz and Jay have all got their hands up, so to speak. But any other students? Otherwise, we'll pass to...
I can say, see a hand, Jay Johnston, I don't know if he's
starting. There's Marcel and Maz as well in the chat, but go ahead, Jay.
Hi, really great presentation. Have you had a chance to look in people with TB at their instance of immune reconstitution, like IRIS, HIV negative virus? And have you looked at their pulmonary outcomes? Just anecdotally, I noticed that low BMI is associated with very significant IRIS and very significant lung disease post-TB. And I'm wondering if you have any data on that in particular. And then the second question I have, sorry, and just maybe a second question completely unrelated is, do you have any ability to model, I know you don't have any specific outcomes right now, but do you have any ability to model to compare nutritional supplements to like a latent TB cascade of care? So latent TB cascade of care doesn't work very well, but presumably nutritional supplementation would be massively taken up. And I just wonder which one, like if you had a choice, which one would you do? I would hate to imagine you'd have to have that choice, but to convince people that nutrition for contacts would be more useful, could you model that out too? Sort of two unrelated questions. Thanks.
So regarding the TB iris, we are not really we are not looking at that outcome in this cohort. But from my experience as a clinician, I've been seeing TB iris actually much before the HIV era. So actually, the TB iris phenomenon was documented in lymph node TB and other forms of TB long before HIV arrived on the scene, but somehow it did not get a name. It was called a paradoxical reaction, and so we do see very often with lymph node TB and also with CNS TB, even in HIV negative. So this is but I don't have a kind of, I have not documented it in my own, clinical experience, but other people have done so. And actually speaking, that it's very frequent. And most dramatically, most life-threatening is actually with TB meningitis. We have seen patients who are, conscious on arrival, and then within 7 days after starting ATT, they have, developed serious complications and even died. So that is one question. The other about the modeling, that's not. It's an interesting question, but it's not in my area of expertise to do that. Maybe, but we can just take it up as a potential, question for the statistical group. Yeah.
So, Marcel or Maz?
Hi, Anurag. It's great to see you again. As you might know, there's another clinical trial by TB Center meeting members led by Greg Fox. And it actually has the same primary outcome, as I understand, which is secondary cases and household contacts. So could you give me a sense of how many household contacts you have that have had co-prevalent disease or incident disease? Because if I understood, that was the primary outcome. Is that right?
Yes. So we have about 10,345 household contacts, and there's a slight imbalance in the numbers in the intervention arm. The intervention arm actually has more contacts than the control arm, about 900 more contacts. So this was beyond our control. So we have about 5,600 contacts in the intervention arm and about 4,700 in the control arm. And at the moment, as I said, you have 150 or more cases in this 10,000, plus contacts, which is around maybe a percentage about 1.5%, I would say, overall. So that's the number, but we are still not completed follow-up in the entire cohort. And actually now, in the first year of follow-up, actually the cohort, we diagnosed relatively few cases, but actually the numbers are rising. The literature says that most people will develop TB in the first 6 months or 1 year, but our experience has been slightly different. Greg Fox, I'm not sure whether he is involved in an intervention study, but of course his papers from Vietnam on active case finding and contacts versus passive reporting, etc., were very useful. Co-prevalent, we had about 27 patients diagnosed at the time that the patient was diagnosed or within the first 2 months. So 27, so we have in total 177 till now, 150 incident and about 27 co-prevalent.
Okay, thanks. Well, that's a good number to be able to determine whether you meet your primary outcome by the groups. Yeah, thanks. Great.
But this is a cluster randomized trial, so that reduces the thanks.
Hey, Anurag, really thank you very much. It was great talk this mess. I have a general question. I'm wondering, historically, TB was even called consumption or wasting. So it appears that there is actually a part of a disease that could cause muscle wasting and reduction in BMI and so on and so forth. So, and I'm wondering, how would you delineate the impact of the nutrition versus the impact of the disease? And because, if you look at historically, in Europe, people even, rich people were getting TB and they become, they will have become cachexic, muscle wasting, and I'm sure that those people were not under malnutrition at all, but it seems like there is, in fact, as part of a disease. So how would you separate these two factors in your studies?
So, as I said, that given that communities from these people are coming, one comparison is what is this nutrition status of the so-called healthy contacts. And even there we find that low BMI is there in 30 to 40% of men and women. So it is very likely that before even they develop TB, they were already, underweight. Another thing which is an indirect evidence is indirect evidence of the long-term nutrition of these people is their heights. So TB cannot reduce the heights of anybody, So when we see the heights, again, there is a lot of, the heights are low in India. So you have people who are underweight also have stunting and then develop TB. And when you add the fact of delayed diagnosis to all these, to this dynamic, then you have, severe forms of, wasting. So it's a combination of not only the pre-existing undernutrition, the disease effect, and if you are undernourished, you have more extensive disease, and the fact that there is a significant delay in your diagnosis and initiation of treatment. That is what you see here. But in a patient at the time, the other way of looking at it is what happens when the patient gets treatment. So if it was entirely due to disease, then they should come back to normal. But that is not what is happening in patients with TB in India. They remain underweight. So that is another way of looking at this issue. But I think what is not regarded in this whole discussion is whether the nutrition status is the effect of disease or whether it was pre-existing undernutrition. What are the implications of that low BMI? That is what we should be most concerned about in a patient. So the BMI is 13. For the clinician, it is maybe important to address that low BMI, actively, and that is not what has not been done. We have been, and that is something which I feel is serious and an urgent imperative. So
in that case, I guess your hypothesis is that malnutrition increase susceptibility to infection, to initial MTB infection. Am I correct?
Yes, not to infection, because nobody has really proven that malnutrition increases the risk of infection after exposure, but definitely there is consistent data that it increases the risk of progression from latent TB to active TB.
Fantastic. Thank you very much.
Okay. Yes.
Great. Okay, it's 2:00. I don't know whether the recording will stop or whether the whole thing will shut down suddenly. So just in case, I did want to thank you, Anurag. I'm sorry again, I missed the beginning on clinical service. I see there's a huge crowd that has joined this to listen to this talk. So that's nice. It kind of reflects the interest both in the topic of malnutrition and TB, which you've been championing for many years, but also, of course, the interest in this ongoing massive clinical trial, which, again, the final results we're still anxiously awaiting, but the preliminary results look pretty dramatic so far. So, I don't know if this recording suddenly stops, so that's why I'm kind of trying to talk quickly to thank you in case I'm gone. But really, thank you very much, Anurag. It was great to see you, hear you, and frankly, great to see all the interest generated by this.
It's been wonderful actually working under you and with all the team there. So I can just express my thanks again for that. There was one other question in the chat box, but I wonder if I can stay on it for time. So,
feel free to keep going. I just personally I have to go back to the work, and also again, it does seem as though we haven't suddenly expired our account. So. Please.
Somebody, Jonathan asked whether there's a plan for passive longer-term follow-up 5 years down the line, and Well, we don't have any such plan at the moment because, again, our trial is of 3 years duration. But yes, down the line, maybe if some other group takes it up as a follow-up thing, it could be good. Yeah, that is the most robust, actually, evidence of what happens, long term to these people. And yes, we would really like to see the association of baseline BMI with long-term outcomes. So I think if there are no further questions, we close the session. Lysandra, are you going to?
Yes. Here. Yeah, so thank you very much, Anurag.
Thank you.
Keep in touch.
Yes. Thanks to the audience also, and many of my colleagues in India have braved the ungodly hour to stay with this session. So thank you for them also, and thank you for all the encouraging words. Some of my members of our team are here, so they must have been really encouraged to hear this support. So thank you so much again.
Amazing work to your whole team. Thank you.
Ciao.
Yeah.
Recording stopped.